Good morning and welcome to this session on challenging cases in ocular oncology. I'm not seeing my co-moderator Vishal, he's probably stuck somewhere, but because of time we must continue. We have four presentations, one on choroidal tumors by Dr. Gavin Tan from Singapore. Vishal from LV Prasad will talk on optic disc cases. Dr. Tarjani from LV Prasad will talk about, I guess, orbital tumors. And I will speak on unusual iris tumors. So Gavin has to go to another session, so we'll just kind of go that way. So you have 12 minutes, looks like. Maybe you speak for 10, and we have 1 or 2 minutes for discussion before you go. Gavin, thanks for being here.
Thank you for inviting me. Let's just load this. Okay, so I'm going to take us through a case, and I think the case just sets the scene for how we should approach choroidal tumors that are atypical in general. So this was a 55-year-old Chinese man, not much medical history, hypertension, dyslipidemia, quite expected for the age, had no systemic symptoms. He did, however, have a history of penetrating trauma with some surgery done when he was a child, so we couldn't get a great history. But we know that eye had poor vision and amblyopia since, but he was previously still able to make out 660, and vision had worsened over the last 1 to 3 months. So right eye vision was normal, the left eye was only counting fingers. In the left eye there was an old cornea scar which consistent with his history of ocular trauma. And in the left fundus we see this large, pale, slightly hemorrhagic looking, irregularly shaped tumor. And the tumor looked very vascular on a close-up clinical examination. And the other eye was unremarkable. The OCT showed some subretinal fluid, and it was pretty much a solid tumor. Does not look like a vascular hemangioma, for an example. So it was a solid tumor. And the interesting finding, and I think B-scan is always very important when we evaluate choroidal tumors. We know the classic melanoma description, which is low internal reflectivity. We know the classic hemangioma vascular tumor, which is the opposite end of the spectrum, where you get high internal reflectivity. Here, this tumor appeared to have to be kind of what I would say is biphasic. There was at the anterior portion, which had a high interior reflectivity, very bright signal. Then a slightly lower internal reflectivity, almost but not quite an acoustic hollowing kind of appearance in the deeper layers. And that was consistent throughout the various cuts of the B-scan. And the angiogram showed hyperfluorescence with a large amount of late leakage. The ICG showed some vascularity, but did not have an appearance that suggested this was either inflammatory or a choroidal hemangioma in origin. So I think very often in atypical choroidal tumors, we think of whether it's melanotic, amelanotic. Melanotic, we would always think of melanoma first. In the amelanotic tumors, you still need to think of metastasis as the most common, because that is the most common adult tumor that you will still find. But you need to think of the other differentials as well. In this case, as I mentioned, there was high to moderate internal reflectivity. It was quite a large tumor, height of 7 millimeters, base of 15 to 16, and leaking on an angiogram. So we were thinking along the lines, was this maybe a vascular tumor because of the vascularized appearance? There was a consideration, a capillary hemangioma, but it does not appear to be that kind of appearance. Because of the pale nature, could be an atrocystic tumor. Because of its nature of trauma, was this old granulomatous lesion. And of course, you did want to rule out Mets. I think this slide just gives a breakdown of what the appearance or differences would be for these other common tumors that we might find in the retina and choroid. And you can see B-scan tends to be very useful to distinguish melanoma from the rest. Angiogram is useful in delineating the vascular tumors, and so on and so forth. Yes.
Before you go any further, have you established or have you figured out, is it a choroidal tumor, retinal tumor, or arterial?
So based on the B-scan, we think it is a choroidal tumor because I think in one of the cuts you can see what looks like the overlying Brooks layer, and we thought this was almost like a pseudo collar stud kind of appearance. So it had a portion that was sub RPE, so in the choroid, and it had a portion that had penetrated Brooks into the subretinal layer. And as you can see in the ICG, there's an area of block senescence as well as an area of increased vascularity. Yes, it's obscuring the disc. Correct. Yeah, it's involving the disc. And that's why at one point the differential that we're thinking of, is this a peripapillary or an optic nerve tumor? That was a differential as well. So I'll go on. Any other questions, thoughts? I'll show a bit more imaging, then I'm gonna open it for differentials because this one was a very challenging case. So an MRI was performed, and we had a long discussion with our neuroradiologist, who felt very strongly it was a vascular lesion based on the MRI because of the amount of enhancement. The posterior scleral margin was well preserved, but obviously they always caveat that a primary malignancy needs to be considered and serial follow-up for growth. That's the standard radiology statement you tend to get. We also did a PET-CT scan just to ensure there were no lesions elsewhere, and other than an intense FDG positive lesion where that tumor was located, there were no other hypermetabolic lesions elsewhere in the body. The other investigations were all remarkable except for TB quantiferon positive. His MANTU was negative, and he had no signs of pulmonary tuberculosis. So again, differentials, and what would you consider? I was hoping to ask the panel what they would have considered to do in this case here.
I don't think there's any imaging test that will tell you what it is. So you have to have a tissue diagnosis. I mean, you can look at the B-scan, you can look at MRI, you can look at anything you want. It's not going to tell you what it is. You suspect many things. And if it doesn't fit in anything particular, then you're really... That's my take on it.
Anybody else have an opinion?
Okay, we'll carry on then.
So we discussed the option with the patient. We were very keen on doing a biopsy, but again, because of the position, we know a biopsy is an invasive procedure, so the alternative was also discussed with the patient whether you wanted to serially monitor for growth. I think the patient decided he probably wanted a biopsy. That was arranged, and within a month, we felt the lesion was growing, and that was arranged about 6 to 8 weeks after the initial consultation. I don't have the full video, but what we did notice when we did this biopsy was the superficial layer was necrotic vascular bleeding tissue. When you went a little bit deeper, you ended up hitting what we thought was Brooks membrane. And below that, when we tried to get a deeper core, it looked like a slightly more pigmented tissue under Brooks membrane. And so we got two bites, one of the superficial and one of the deeper tissue. And that was the plan because we saw that kind of unusual biphasic appearance on the B-scan ultrasound. And the mass had grown even larger from the prior visit. And there was a much more extensive exudative retinal detachment. And at that time, we decided, because we had to make a larger retinotomy in order to access the deeper tissue, and there was a lot of exudative retinal detachment. We filled the eye with silicone oil. We sutured all the sites and did, of course, cryotherapy on all the sclerostomy sites. This was the post-operative image. And this was the tumor block. And this first block, I think, was from was the deeper tissue, where it shows clusters of atypical cells with melanocytic origin. And most of the stains, S100, CD68, were negative. Ki67 proliferation index was really borderline. Our pathologist didn't really feel it was significantly raised. And just because of the quantiferon, we also stained for acid-fast bacilli, which was all negative. This is a zoomed up area. As you can see, almost a spindle-like cell appearance. Not too much nuclear atypia. There's a little bit, and not much mitotic figures being seen either. And this was another area of the cellular regions, and most of the other staining was negative. This was the more superficial portion, which mainly showed necrotic cells, so that white vascular, much more soft tissue that we saw in the biopsy was mostly necrotic cells. And these were the staining, not too much significant. So I think the conclusion from this we felt was it was an atypical melanocytic proliferative lesion, and the call based on that core biopsy was likely a melanoma. So in this patient, I think in view that it was a melanoma, in view of the size and proximity and likely involvement of the optic nerve, and enucleation was performed, and the histology confirmed that diagnosis, and it appeared on the full histopathology that the superficial, that pale vascular area was a portion of the tumor that had breached Brooks membrane, and it had a lot of vascular congestion and necrosis, and which is why it gave us that very atypical appearance, that vascularity that seemed to trick us into thinking it might be a more vascular lesion rather than a solid tumor. Unfortunately for the patient, liver mets were detected 1 year after enucleation on his regular MRI liver follow-up. So I think in conclusion, this represents what you may typically see with amelanonic tumors. If there are features that confirm a diagnosis for yourself, then you would treat it as such. But if there is diagnostic uncertainty, I think a biopsy can be done, and a biopsy is quite a non-invasive procedure now. Often you can do it without too much issues or complications. But in this case, it turned out to be a melanoma, so the patient had to lose the eye. Any questions, discussion,
very
or thoughts?
Very nice presentation, thank you. So it's a further melanoma with optic nerve invasion.
Yes.
You can see some infection, you see optic nerve. The treatment is enucleation for that. Very nice case. Any questions or comments before we go to the next presentation on optic disc tumors, right? You're going to present on that. Continue on optic disc.
Okay.
Thank you for being here. Come back when you're done with the other talk, okay? Gavin?
See you later. See you.
So next presentation is by Vishal Raval from LV Prasad Institute.
Okay, so good morning. So I'll be presenting an interesting case of optic. I'm not sure my slides are not visible. Can somebody? Yeah, okay. So good morning one and all. I'll be presenting an interesting case of an optic disc tumor, especially which was very unusual location for me to kind of and had a kind of diagnostic dilemma how to deal with such kind of tumors. So I have no financial disclosure. So directly going on to the patient. This was 71-year-old male, complained of diminution of vision in the right eye, which was sudden, just 1 month back, and past history of a chronic smoker for 25 years, no other associated significant past history. Left eye visual acuity was NPL, and rest of the anterior segment in the right eye was absolutely okay. Left eye had RAPD with normal intraocular pressures. If you go the fundus photography, this is what kind of patient presented to the clinic. You could see a large kind of amelanotic lesion, 4 to 5 disc diameter in size, which had a kind of very irregular margins with surrounding cuff of subretinal fluid with few specks of intraretinal hemorrhages. On the surface of the lesion, there was no kind of pigmentation, but you could see there was intrinsic vascularity, which is.
Yeah, I'm going to ask the audience to tell the diagnosis.
Okay. Yeah, so I think this was what the patient presented to the clinic, and looking at this, particularly in a country like India, we usually come across few differential diagnoses before we jump on to oncology. So I think I will ask the audience, what do you feel when you see this kind of cases in your clinic?
We'll go around from here.
Yes, sure.
Please tell us your name and where you're coming from and what do you think it is. Make the best guess. Everybody's guessing, okay, so you can guess.
I'm from Japan. A very difficult, strange appearance. I didn't see such a tumor.
Any guess? You want to make any guess at all?
Very, very difficult.
No problem. You, Handa? Yeah. Okay, here's the next one.
Yeah, Handa from Taiwan. So based on the age and posterior location, and the proximity to the disc, and the color of the lesion. I would first impression will be astrocytic hematoma.
Okay.
Yeah.
Good.
One diagnosis, one diagnosis.
One
If you're
differential
right or
we
wrong,
have.
We'll figure it out. Okay, and how about you, sir? What do you think?
Yeah.
You're as good as anybody here.
Yes, yes. I think what he says, I also feel the same. No other clue.
Okay, no worries. I'm going to quickly. Anning Chow, also from Taiwan. Go ahead. Anning.
Yeah, I agree, but we also have to rule out like matte because of the color. So this is one of the differentials.
Metastasis.
Yes.
How about you, sir?
Yes, to me also looks to metastasis. Yes.
Metastasis. Very nice. Okay, NLP vision. And madam, what do you think it is? Just make a guess if you are familiar with the term.
Metastasis.
Metastasis. How about you, sir? Not familiar with this? How about you? You want to say something?
Yes, Rajanavan is there.
We have the expert walking.
Mudit is also there. Okay, he knows the diagnosis.
I know, I agree with the first two as well, but I did my training in Cape Town, and there we're taught to always think of TB, so maybe TB granuloma or something.
Rita, well done. What's the diagnosis? Just quickly. Nothing here. NLP vision, what do you see? Hi, Bhamna, very nice. Hey, we got an expert panel, right?
Yes.
50. Adult, 70 years old.
Adult?
70-year-old.
70 years.
No perception of light. Let's be quick, we don't have so much time. Bhamna, go ahead.
With what?
Diagnosis.
Age?
71.
70.
NPL, no PL.
Metastasis. What do you think? Metastasis? What do you think? Okay. Everybody said metastasis. That may be wrong, but that's fine.
Okay, I'm happy. So we went
We'll
ahead.
carry on. We'll find out. I don't know.
Yes, we'll.
I would say, okay, I wouldn't say anything, but it's okay.
Okay, so we went ahead and did the imaging what we had in our facility. So again, I think one of the audience told us about retinal astrocytic hematoma, and I think hematomas are usually associated with calcification. And you can see on the ultrasonography, we couldn't see any kind of calcification. This was a solid homogeneous lesion, particularly arising kind of from the retinal structures. I think underlying choroid or even the optic nerve doesn't look kind of involved or dilated or kind of edematous. You do the OCT imaging, again this shows the location of the tumor. Again it is kind of more in the retinal compartment than in the choroidal compartment with surrounding subretinal fluid, as well as you could see there was a posterior backshadowing suggesting that this is a solid homogeneous lesion, not a something kind of heterogeneous lesion or a kind of cystic lesion which might be kind of determining the underlying choroidal compartment. You do invasive imaging such as fluorescein and ICG angiography. You could see from the early to mid to late. You could see early hyperfluorescence, which kinds of increases in intensity, as well as kind of phase, where in the late phases you could see leakage, particularly in the subretinal compartment because of the associated subretinal fluid. OCT angiography, we have a tool, so we just kind of wanted to see how it looks, because on clinical examination there was a huge intrinsic vascularity which we could see on the kernel fundus photography, and this was nicely depicted on the OCT angiography, the intrinsic vascular, the intratumoral vascularity of the tumor. Yes, doctor.
So this intratumoral vascular, is it choroidal or is it retinal?
Retinal.
This is retinal vascular?
Yes. So this is the slab what we have taken. This is in the deep capillary plexus.
Does that,
Sorry. Yeah. So the next investigation imaging, because we couldn't identify or see the optic nerve, we didn't know from where it is arising or whether the underlying optic nerve is involved or not. So we went ahead and did an MRI on hyperintense. It showed a kind of T1 on hyperintense and T2 hypointense lesion. Again, the longitudinal part of the optic nerve, whatever we could see on the cuts of MRI, looks absolutely okay. There was no dilatation or kind of tortuosity or enhancement on the retrobulbar part of the optic nerve. So this was a lesion which was sitting over the optic nerve, but it was not affecting the general length of the or the proximal part of the optic nerve. So then there was diagnostic dilemma. We don't know what it is. This is the amelanotic optic disc lesion. We sent to our uveitis clinic to rule out any inflammatory granulomas, but sudden loss of vision, NPL, 1 month duration, unlikely it will be inflammatory, but we do work up our all kind of granulomas for inflammation, in particular in country like India, for tuberculosis sarcoid, and all the tests came out to be negative.
Why is it not melanoma?
It can be, but I have not seen amelanotic optic disc melanomas. At least I have not come across this kind of presentation for a melanoma onto the optic disc. So my differentials were mostly, as most of you pointed out, to be metastasis, and whole body PET CT scan was done. It showed some kind of lymph nodes positivity in the apical region with a small cystic lesion seen on the 6th rib. Now we went back to the medical oncologist, asked them to take a biopsy, but then they told it is in the rib lesion. It would be detrimental for the surrounding structures, especially the pleura of the lung. So considering the location of the lesion, NPLI, and we being retina specialists, it is easier for us to put a needle and take a biopsy. We went ahead and took a vitrectomic based lesion biopsy and sent for cytology. So this is a small video which demonstrates how we took the biopsy for this lesion. So we directly went ahead with a 25 gauge vitrectomy system, and to my surprise, this was not that kind of thick or kind of solid lesion. It was more like a cheesy lesion. It came out very easily with the cutter kind of aspiration, as well as your minimal cutting, 100,000 cut rate per minute. And once I took the biopsy, as you can see, it was a highly vascular lesion. So there was some bleeding which was associated with that, which stopped with the raising the intraocular pressure. So the cytology, again, it's shown on kind of cell block, loose clusters with single scattered and few glandular patterns. But important feature, what we could see, there was a signet ring-like cells with multinucleated giant cells within that. So I think this raised our suspicion more towards metastasis, and then we ran for both pass stain, which showed the signet ring cells stained red, seen on the left-hand side photograph, as well as the Alcian blue, which show the blue color cells, particularly positive for the acidic mucus, which is very characteristic of mucin-related carcinomas. Pan-cytokeratin again was positive, showing diffuse and strongly expression in the cytoplasm as well as in the lesional cells. Just as Dr. Singh told about melanoma, HMB also we regularly do to rule out melanoma, and that was negative, thereby ruling out any melanocytic origin of the tumor. So cytological diagnosis gave us a provisional diagnosis of optic disc metastasis, possibly from the aerodigestive tract because of the mucin, either from the lung or from the gastric adenocarcinoma. The whole body PET CT scan, as I told, showed some lymph nodes involvement with the right 6th rib lesion, and we went ahead with the further IHC markers, especially to rule out whether it is a lung or it is a gastric adenocarcinoma. And as noted, CK20, which is a very strong expression for lung adenocarcinoma, as well as thyroid transcription factor 1, which is again very strong marker for lung adenocarcinoma, both were negative. So that pointed out towards the final diagnosis of signet ring gastric adenocarcinoma. Follow-up patient was referred to the medical oncologist for further screening of the possible primary from the aerodigestive tract, especially gastric region. A lymph node biopsy was advised. However, the patient deferred for any further investigation in view of his poor health status. So my message is, I think multimodal imaging does helps in our few of our oncologic cases, particularly if it fits into your criteria wherever you want to look for a particular tumor, whether it is arising from the retina or the choroidal compartment. Invasive imaging, especially ICG angiography, does helps particularly in cases where you want to look for the vascularity or the surrounding structures associated with the lesion, especially retinal detachment or subretinal fluid. Last but not the least, I think biopsy, clinches the diagnosis, especially in cases where there's a diagnosis dilemma or you're not sure about how to go about in such cases. And optic disc metastasis, as I say, it constitutes very small cases of retinal or the choroidal metastasis compartment of the disease. And as we all know, prior cancer history is present in only less than 50% of cases. So as an ophthalmologist, we might be the first person to diagnose a underlying primary elsewhere in the body. And that's why a role of multidisciplinary approach or a very good dialogue with your medical oncologist as well as your surgical oncologist will be fruitful. Thank you.
Let's look at the first photograph again, just to kind of get in some thoughts about it. Now we know what it is. I guess because it's centered on the disc, you can't tell what kind of circulation it is. Is retinal or choroidal? I mean, I can argue that this looks like, if it goes outside the disc, it looks like choroidal circulation.
Okay. Yeah, I think one thing might be the retinal vascular surrounding are absolutely okay. There is no dilatation or engorgement of any of the vessels surrounding the lesion. So that might give a clue that it might not be arising, but the OCT, as I showed, again, yeah, this. So I think here, I think underlying at least the surrounding choroid in the lesion in and around the adjacent choroid looks absolutely okay. There is nothing in the choroidal compartment in that particular area.
And the other thing we always say, metastases have disproportionate amount of detached retina.
Yes, exudative RD.
And we have no exudative RD.
There's no exudative RD, yes.
Which is kind of very atypical,
Atypical.
for metastasis.
Yes.
And solitary and nothing else. So
Nothing else.
To take you to metastasis, except you say it's yellowish color, but I couldn't really tell whether it's really retinal or choroidal. I thought the circulation looked more choroidal.
Mm-hmm.
Like a ribbon-like pattern,
Yeah.
So this would be what we would see with intrinsic vascularity of melanoma.
Melanoma, yes, that's what I was thinking. Double circulation, what we see, both retina circulation as well as the choroidal circulation.
Right, sir?
Okay.
Excellent case. Thank you
Yeah,
very much.
thank
Any
you.
comments? Anybody has any comments? No? We have one other presentation, but that's orbit, right?
Yes,
Okay, and before that is mine.
yes.
So we have time. How much time we have? We have another hour, right? Yes, 11:30. Rajani is here? No, not yet. But she's last. Okay. So I'm going to show multiple cases, short cases, because when you're talking about differential, it's good to see many side by side. You think of this, and then you don't know what the other thing looks like. So I'll talk about unusual iris tumors. Are you seeing my slides? I'm Aaron Singh from Coal. So iris tumors are uniquely challenging. They're common, they're small, there are many types, and many patients are asymptomatic. So think about this, even in many kinds of tumors, then it's hard to know or for us to figure out the patterns of them because there's so many kinds. And if you look at the iris, obviously it's not one structure, many tissues, many layers. And I can tell you the tumors arise from each component of iris. So you can have tumors from melanocytic tumors, we are very familiar with those. You have stromal tumors, vascular tumors, muscle tumors, and of course tumors arising from the pigment epithelium. So think of iris as multiple layers, like you think of cornea. Always think of corneal dystrophy, epithelial dystrophy, stromal dystrophy, endothelial dystrophy. Same thing of iris. You can have tumors on all different layers. And we typically do history examination, those kind of things, but ultimately you have only 3 imaging tests we can do. We can do fluorescein, we can do UBM, we can do OCT. That's all you can do for an iris tumor. And we have clinics full of patients who have every test but no diagnosis. So that's why I always want to come back to the clinical photograph, because that's what's driving your diagnosis. You can do any test, but test doesn't tell you the diagnosis. Okay, so test only helps you. And in iris tumors, you have only 3 things that you can pretty much do. You can't do 7 tests. There's nothing else. And after that, you can only do 4 things to that patient. You can observe them, you can biopsy the tumor, you can do radiation, and if you think it's really something bad, you enucleate them. You have only 4 options. You have no 5th option of treating the iris tumor. And that's, of course, driven by your clinical diagnosis. So if you think it's benign, you may observe. If you think it's malignant, you will biopsy. And if you think it's like malignant and extensive, you think about something. So it's all driven from clinical diagnosis, basically. So you really have to come back to the clinical findings. So I'm going to go through 5-10 quick cases in a few minutes, okay? So as a patient, you can see something in the angle. You can see it's coming from perhaps ciliary body and eroding the root of the iris. We can see that. So it's not really an iris tumor as such. We say this is an iridociliary tumor. And the moment you reach iridociliary tumors, we enter a whole different complexity. Just like you reach optic disc tumors and you don't know which layer it's arising from, the moment you cross iris and reach ciliary body, it gets a little bit more complicated. Because ciliary body is not visible. Only way you can assess ciliary body is through UBM. So if you don't do UBM, you don't know anything. So you did gonio, you think it's in ciliary in angle, or certainly root of ciliary body, and you did UBM, you can see that here, and you can get an idea that this tumor is trying to go outside its boundaries and entering the sclera. We can see that, right? You can get that? You can all see that here. What I'm pointing out right there. So that made me think that this could be some kind of invasive tumor. It's whitish yellow. So we talked to the patient, and he wasn't very keen to come back many times. He said, "Just tell me what it is, and I can't keep coming back." No problem. I excised it. I like cutting. I excised it, and come back as sarcoidosis. So this was sarcoid granuloma in a patient who has nothing else going on. No KPs, no iritis, no known sarcoidosis. So there you go. I said, no idea what it is. When you remove it, you figure it out. And that's the motto of this lecture. You don't know what it is. And there's another one here, very similar location, darker, of course. So we know it's melanocytic kind of tumor, nevus versus melanoma kind of discussion. But it's not iris. You can see it's coming from ciliary body. You can see that on gonio examination, correct? That's convincing enough. And you did UBM, you say, yeah, it's partly solid, partly cystic. So can this be melanocytoma, for example? Okay, that's the other differential. So in any way, I don't think I could do anything. You could sit on it, or you can biopsy it, whatever. I excised it, and here it is. And this was actually a ciliary body nevus. So now you think about it, you say, I know about iris nevus, and I know about choroidal nevus, but never heard of ciliary body nevus. Well, what makes you think the ciliary body nevus does not exist? Well, it exists. It's just that we can't see them. We can't diagnose them. We can't, because we can't suspect them. But they are happening. So I saw 3 of them. Okay, I published them. But you'll only figure out if you cut them out. I don't think you should cut everything, but I'm just saying there is something called ciliary body nevus, and we should not be surprised about that entity. Well, look at this case here. I say, yeah, small roundish tumor, 18-year-old, 17-year-old young man. And on UBM, you can see stromal tumor, completely spheroidal, centered on the stroma of the iris. So say, yeah, melanomas are stromal tumors. This is pigmented, is 17 years old. It could be nothing, just a nevus, go home. Except that I had seen him before, some years ago, and I had seen this photograph. So I said, this is a growing tumor, melanocytic tumor, in a young man, 17, 18 years old. So for me, growth in short period is significant. I excised it. And this is melanoma on pathology. Here it is, melanoma, no doubt about it, mixed cell type. And this is what he looks like after pupilloplasty. And look at this kind of brown tumor. It's sitting on the iris. It's not distorting the stroma. There are no vessels. There's nothing else. It seems to be just sitting there. And we know melanomas tend to be vascular, particularly on fluorescein. So you can do anterior segment fluorescein. We did that here for the iris. And it's totally dark. There's no vascularity. It seems to be disconnected with the underlying iris. We didn't have, this is before the time of anterior segment OCT. This is many years ago. We did a UBM, however, and you can see that it's sitting on the stroma. It's not centered like the other case, up and down. This is sitting on top of the stroma, and I could actually see the stroma right there. You say, this is the anterior stromal layer, and this is sitting like a ball on top of iris. That's the impression you get from looking at it. So we don't know exactly what it is, and so I excised it. I took a super sharp blade and found that plane. I just dissected right there. And you can see the dissection. Iridectomy was not done. We didn't think it was malignant. So we spared the sphincter, spared the stroma, and shaved it off just from there, that stroma. And it looks very nice postoperatively. And this is an iris varix, a rare kind of iris vascular tumor. You would never know if you didn't take it out. So there you go. Okay, so we don't know what it is. It's not melanoma. Take it out. But here we have somebody with a kind of a mass, fleshy mass in the angle. The eye is inflamed, pressure is up, neovascular glaucoma. He's an elderly man from a nursing home, no prior history. He has dementia. He does not remember anything. So what you say, it could be anything. But in terms of tumors, we would say it's more likely to be a metastasis, because metastasis causes inflammation. Metastasis can cause neovascular glaucoma. So we biopsied him with a needle aspiration biopsy, come back as renal carcinoma. And then go back and look in his history. He had a nephrectomy some years ago. He had forgotten. He had dementia. He doesn't remember. So it's a renal metastasis. So what can you do just to simplify? You put a plaque on it and give intracameral Avastin for neovascular glaucoma. 4 weeks later, he looked fine. Send him away. So you can get metastasis, eye is inflamed, and you can see neovascular glaucoma. But here's an kind of similar tumor, more kind of quiet eye. This is a 24-year-old man, goes for a contact lens fitting every year. And this time when he goes for contact lens check, they see this tumor. He has no symptoms of any kind, so no inflammation, no pain, no nothing. He's a college kid and comes home every summer and goes for the eye checkup. And so this is new onset tumor, recent onset, and you go look closely, you can see vessels in it. So that makes me think of melanoma. When I see this kind of uveal vessels, it makes me think of uveal melanoma. So you say, oh, this could be melanoma. Eye is quiet, he's 24 years old, but you can see fine vessels in it. So I did not want to do needle biopsy here because it's a highly vascular tumor. I thought I'd get bad hyphema. So I just wanted to excise it. I excised it, and this he looked like it was melanoma. So I just showed you totally translucent melanoma. Okay? Not FNAB, totally excised, completely confirmed. And he looked fine. And here's another translucent mass, also very, very vascular. Much more vascular, a different kind of vessels than the other vascular tumor that I just showed you. And it is on fluorescein lights up, not surprising. So again, I don't want to do needle biopsy here because we'll get bad hyphema and may not be enough cells. So you have negative biopsy and a big hyphema, not a good outcome. So I told him we could excise it because we don't know what it is. Anybody has a guess as to what this may be? I didn't know what it was. I said, it could be melanoma. Always think melanoma. Anyway, it was excised. It was a leiomyoma. So why vascular? Well, it's arising from the smooth muscles of the iris vessels. So iris vessels have arterioles, and arterioles have muscle, and it's arising from that muscle. And because it's arising from the muscle of the vessel, it's vascular. But it's not a vascular tumor by itself. It was excised, and we have a beautiful case. And so I showed you this patient with a sarcoidosis. So in the summary, I've shown you tumors of all kinds. And think of all layers. I didn't have a chance to show you some iris tumors. And most of it has come from the book that's been recently published. You can read more about it. Thank you so much. Any questions, any comments? Yes, Honda. Bhavna, you also speak something. Rita, you also speak something. Jonat, you also speak something. Everybody is learned here in the room. Okay, go ahead.
Very nice cases. And so I'd like to have a broad question regarding the choice between fine needle aspiration biopsy versus excisional biopsy. So I always worry about hyphema when I consider fine needle aspiration, but for a larger excisional biopsy, I also have other concerns. So it's always a bit tricky to mess around the anterior segment.
Yeah, you don't want. That's why the patients are asymptomatic. They have 20/20 vision, so that's a challenge.
Yeah.
So the golden rule is as follows: if you think it's melanoma, clinically, then do FNAB. If you think it's not melanoma, do excision. You could be wrong in the end, doesn't matter. But if your clinical impression is melanoma, you do needle biopsy, you can put a plaque. If you think it's not melanoma, excise it.
So plaque is immediately following aspiration biopsy?
Yeah, within few days.
For the cytology.
Yeah, cytology will take about 2 or 3 days. In one day in our center, or the next day we have the answer. So you can wait 4 or 5 days for the eye to settle down a little bit and just do the plaque.
Okay, so for one case that's sitting on top of the epithelium, that case, how do you pull the tumor out?
How did I? Okay, I didn't have time to show the surgical technique. We used what's called small incision guided hydroaspiration. So think about the DMEC cannula. Okay, so you make a paracentesis incision or keratomic incision, 3.2 millimeters roughly. Put a viscoelastic in the anterior chamber, take DMEC cannula, connect it with a 14 French catheter to a Helon cannula, make everything viscoelastic. And after you loosen the tumor in the anterior chamber, you aspirate into the cannula, and then you withdraw the cannula. So it's a guarded hydroaspiration. Okay?
Interesting. Thank you
All
so
right.
much.
It's more about this technique, but I didn't talk about it. That's why you get beautiful outcome, because you have a very small incision. You have 3 millimeter incision. You did not make a 8 millimeter corneal incision. Yeah.
Thank you so much.
Yes, sir. Yes, donate.
Thank you, Professor Singh. That was very impressive. I have two questions. The first one, Honda just addressed it. The second question is, when do you perform the pupilloplasty, and when do you decide not to do the sphincterotomy, and when do you decide to do it?
Yeah. Well, if it's a stromal tumor, you have to cut the stroma. And many, if it's melanocytic tumor, we stay away from excision, so we'll do FNABs. Because if it's beyond certain size, you cannot do pupilloplasty. I do pupilloplasty at the time of surgery. But if you have bad hyphema or somehow you're not able to do it, it's okay to come back another time. Okay, for example, we had a patient one time, we did the sector iridectomy, did not know what it was, and there was really bad hyphema, total hyphema. As much anti-tamponated aspirin, I did whatever I could. I could not clear the hyphema, so I just stopped. And I told the patient, we'll see, control the hyphema, we'll come back later and do it. And afterwards, she said she was fine. She was not bothered by the sector iridectomy. She was wearing a contact lens, and there was no need to do pupilloplasty. So you can stage it. If patient is pseudophakic, it's easier to do pupilloplasty. You put the needle through the tenoprolene suture. But patient is phakic and young, then you can have a little difficulty. So you could stage it if you are having any difficulty about making your mind up about it. Okay.
Thank you.
Vishal.
Thank you for the interesting cases. So one question is about the melanoma of iris, what you showed. So how is your surveillance protocol, particularly for the metastasis? Because from the choroidal compartment, we know how to kind of follow up these patients. Now the iris or even the ciliary body and the melanoma, because we know ciliary body, the vascularity and the metastasis might already have gone. So is there changes your surveillance protocol to look for metastasis in this group of patients?
So we follow the same protocol for all uveal melanomas, whether it's iris, ciliary body, or choroid. We know iris melanomas, chance of metastasis from 0 to 1%. Pure iris melanomas, and ciliary body is like uveal melanoma, so choroidal melanoma, so you don't go there. Talking about pure iris melanomas, I have about 150 cases in my clinic. We have 0 patients with that metastasis. But that's, you can say, yeah, you're not going to get metastasis, but you have no real proof of it. There are cases in the literature, some patients getting iris melanoma with metastasis. So the moment you say it's a uveal melanoma, we do the minimum. And minimum for us is ultrasound of the liver every 6 months. That's about it. So basic baseline, we'll just do this. And that's what we offer. After 5 years, you can stop it if you like. But I wouldn't do nothing, because you have a clinical diagnosis of melanoma, and so you are kind of forced to do some kind of surveillance. In any primary tumor, you have to do some kind of surveillance. So there's no exception. So you say it's good news, it's not going to happen, we're not worried about it, but you should do it. Okay. Bhavna, you look very thoughtful.
Yeah, no, very impressive cases and really very nice. I was just wondering, what do you do if the FNAC is negative? Like,
okay.
we tried FNAC in few cases, turns out to be negative, and we still
So
have
that's the biggest problem in FNAB, FNAC, same thing. The problem is really not in the surgical technique or with the surgeon, except how you're handling the sample and who's reading it on the other side. So first of all, we don't do dry smears, okay? So that's totally bad. It's all liquid-based cytology. So you take the needle, you rinse it into cytolite, is what we normally use, spin it down, etc., right? So liquid-based cytology is going to give you a very high chance of positivity. So that's number one. And number two, I would say, is the cytologist. So if you don't have a good cytologist, then your cytology will be negative. So that's all it is. So we can say we have 95% plus in our own data. We have clinically interpretable biopsy report for iris tumor. So I tell the patient, there's 5% chance I will not be able to figure out what it is from the biopsy. And if that is the case, I'll go with my clinical impression. And if I think it's melanoma, and that's why I'm doing the biopsy, I'll treat it. But like anything else, I like to have a confirmation. I have 95% chance I will get a confirmation. But if you cannot confirm, then it will default to your clinical judgment. Yeah. You can't say, because FNAB cannot exclude malignancy when it's negative. Yeah, it could be sampling error, technical error, whatever error. Yeah. Very good question. Rita from Indonesia, Jakarta. Is you having jet lag? Yeah. Okay. You want to say something? Introduce yourself. Tell me where you're from. We have a few more minutes for the lady. Yeah. Okay. Carry.
Ruju Unadkat. I am from Center for Sight. I did my fellowship with Dr. Santosh Unawar, sir. And my question to you is, in case of melanoma, where we have done excision biopsy and it apparently shows that margins are negative, would you still do secondary plaque for those cases, or you would like to keep them for observation and manage them conservatively?
So iris melanoma with resection, negative margins, what should be done after that? If it's negative margin, we would say we will not do secondary plaque, okay? And we know still with negative margins, you can still get recurrences. And we say in our series that recurrence is approximately 3%. So there could be histologic issues in interpretation. Iris samples are very small. They sometimes get folded. When they're processing, the pathologist is not able to clearly tell the margins. But if they say the margins are negative, then we tell our patients a very low chance of recurrence, we will not do a plaque. If margin is positive, then you have to do a plaque. Do you have incompletely resected tumor? You have to treat it. But if a margin is negative, we don't do plaque. For us, that's surgical excision.
Thank you, sir.
Yeah? Okay. Yes, sir.
I am Mudit Tyagi. I work in LVPI in Hyderabad. So me and Vishal actually usually share a lot of cases between us. So both of us sometimes get stuck and have this dilemma. How do you differentiate some of these melanomas from granulomas? Any clues in imaging which can help us in differentiating on terms of ICG or FFA? How do melanomas sometimes they get confounded? We have had some cases which we thought were amelanotic melanomas turned out to be granulomas, and vice versa.
So you're talking about iris, you're talking about ciliary body, you're talking about choroid.
Choroidal.
So you're talking about choroidal granuloma versus choroidal melanomas?
Yeah. Amelanotic choroidal melanomas to be precise.
Okay. So I'm glad you specified that, because when it's pigmented tumor, you have a very narrow differential. Yeah. If it's pigmented, it's nevus melanoma, melanocytoma, or hemorrhage, or some kind of metastasis from cutaneous or mucosal melanoma. So, or B-dump. So you have very narrow differential if it's pigmented. If it's not pigmented, it could be one of 1,000 things. Okay? So this is very important. I'm going to say it's not pigmented. Even then you have 4 or 5 colors you have to choose. Is it white? Is it yellow? Is it orange? Things of that nature. If you say if it's yellow, I think of metastasis or granuloma. If it's more like orange, we say it's hemangioma or some unique kind of metastasis, say renal met or carcinoid met, something very narrow, or thyroid, for example. And if it's white, then you say this could be inflammatory granuloma or some healed process. So things of that nature. So you're looking for associated findings. So if there's inflammation, there may be some retinitis, there may be some vasculitis, there may be some papillitis, there may be some vitritis. So looking for those findings. And of course, onset, is it painful? If there's some going to be arthritis in the front, ancillary findings, patient has rheumatoid arthritis or not, things of that nature. So that kind of thing. Because for me, in my practice, fortunately, it's all been filtered, okay? Uveitis patients go to Uveitis clinic, and I come to, they've been filtered through many layers, and I only get to see tumor-like things. Once in a while would be inflammation. So the commonest inflammation that I see in my clinic would be scleritis. That can look like a met, by the way. Multifocal, yellow-white kind of ill-defined lesions with some detachment and some congestion. You say, oh, is it a met? Is it this? So to me, scleritis comes most. We don't see TB like things in my clinic in the US so much.
Thank you.
Yeah. Okay. So we have some more time. Okay. I didn't bring my computer. We can talk about something else. What else you want to talk about? So you give 12 minutes, 4 speakers, that's 48 minutes. What about the rest of the time? Engage the audience. What do you want to talk about? I didn't bring. I didn't bring it along, but we can download it if you like. So just we talk about I can just explain to you what we are talking about. So in normal surgical technique of sector iridectomy or sector iridocyclectomy, classic iridocyclectomy, you're making a long, a big incision, 6-8 millimeters at the limbus, okay, for the iridectomy, and further back for iridocyclectomy, okay. If it's a mid-stromal tumor, pupil is okay, angle is okay, and you say, I need to excise it, why do you have to make 6 millimeter, 8 millimeter incision, just like you would do in olden days, extracapsular surgery? But you think about laparoscopic approach, you say, I can make multiple small incisions in the cornea and enter the anterior chamber that way. So if the tumor is at 6, you make an incision at 12. And with vitrectomy scissors, the long ones, you can make radial incisions along the tumor after deepening the AC and the posterior chamber, and using angulated scissors to cut the base. So you cut out the whole sector like a pizza slice and float it into anterior chamber. So they're small incisions, okay? So multiple small incisions. So you can make 5 incisions in the cornea, each one is 2 to 3 millimeters, nothing will happen as long as they are not connected with each other. We know that, okay? So you have done all that, come any angle you want, think of laparoscopic surgery, and you're working in the anterior chamber. If the patient is pseudophakic, it's better. If they're phakic, you can still manage with using a lot of viscoelastic. So once you have isolated the tumor with clear margins visibly, about a millimeter outside, then you inflate the anterior chamber and make one of the incisions slightly larger to 3.2 millimeter keratome and use DMEC cannula, which you have connected to the Helon syringe with 14 French catheter that's been cut. So you have a viscoelastic chamber, and the anterior chamber is full of viscoelastic. Then you have the cannula full of viscoelastic. Then you have the whole syringe full of viscoelastic. At the moment you connect the two, the whole thing becomes one system. And then you aspirate it, and this piece of pizza slice floats into the tube. It folds like a taco. And once you've done that, you cleanly remove the tube out. So you have not disseminated the cells to the wound. You have not kind of distorted the iris, because iris is fragile. The moment you hold it, it will shred. So you do not touch it. And then you do the pupiloplasty if you can, and put 1 or 2 sutures to the bigger wound, and that's all there is to it. And once you have the syringe out, you take a filter paper and express the syringe onto the filter paper. The whole thing comes out, and it flattens out, and you send it in formalin. So you did not touch the margins. You can have very good interpretation of the margins, and that's called small incision, guarded hydroaspiration surgery. Yeah, it's published in BJO. You can look that up, and technique also online. Okay. So the iris, I have to say, does not bleed. So if you have prominent feeder vessels that you might in some of the tumors, you can do endocautery. So same cautery that they use in the vitrectomy surgery, you can cauterize the feeder vessels, and you can cut, when you cut radial cuts, nothing will bleed. It will bleed only towards the angle. Just increase the pressure a little bit, and it will stop. Bleeding is not generally a problem, but if there is, for whatever reason, if you went too far down into the ciliary body while making the basal incision, then it's going to bleed. You tamponade, wait, put air, sit for a little bit, and if you can't clean it, just put suture and just come out, and you go back later. But I have to say that's very unusual. There's one case out of like 100. But you will see such cases. So I tell the patients 2 problems of surgery. Number 1, hyphema. Number 2, hypotony, if there's wound leak, etc. But that's very uncommon now with this kind of thing. You only will get secondary ocular hypertension because you did not remove the viscoelastic completely, because the patient is phakic. So I use old-time Simcoe cannula to take out the viscoelastic. So that may be left behind. So give them some oral Damox, and that's fine. So that, for me, because we can excise them safely with small incisions, we have turned more and more towards excision, because I can do it safely. And margins are negative, we have good interpretations, and we are fine with that. Yeah. So who is your last speaker? Not here yet? Yeah. You want to say something? Oh, you have a presentation. Come forward. I did not even notice that. Okay. Bhavna is from All India Institute. I studied there. many years ago. Bhavna, welcome.
So, very good morning. Thank you, Dr. Arun, for putting this all together. And it's always such a pleasure learning from you. There's so much to learn from you. Thank you very much. So, I will be just talking about briefly a case. The topic that I have been allotted is it retinoblastoma? Now, all right, so let's quickly go through this case that we are going to discuss today. So this was a 3-year-old boy who was brought by his parents to our center, and the chief complaints. No, it's not. Okay. Sorry. Should I go that side? Right. So, is it retinoblastoma? Is the question that we are trying to answer today through this case. So, let's quickly go over it. This was a 3-year-old boy. He was brought by his parents to our center, and the chief complaints were that they noticed an asymmetry between both the eyes. And the right appeared smaller than the left. This was since 2 years. And since past 6 months, they had also noticed an upward deviation of the right eye with a whitish reflex in that eye. So, in the past history, the child had a history of meningitis at the age of 3 months, which resolved after treatment. There was no other known systemic illness at present. There was no history of trauma nor any significant family history. So the ocular examination, the right side eye did not follow any light, and the eyeball appeared smaller on gross examination. Rest of the lids, conjunctiva, and cornea were normal on both sides. So we went ahead with examination under anesthesia, and this is what we saw. This was a red cam image. There was this thick membrane which was seen in the posterior segment, but there was no definite mass. So, as the next logical investigation, we went ahead with an ultrasound B scan. It confirmed the presence of a small globe in the right eye. Again, there was no definite mass that was seen. There were some thick membranes in the vitreous cavity. There was some doubtful calcification based on the high spikes that were seen on the ultrasound, and the left eye was normal. So then we went ahead with MRI for more information regarding this mass. So the axial length was considerably reduced in the right eye. And then again, you can see over here on the T2 and T1 weighted images, the T2 showed some hypointense membranes that were also observed on the ultrasound, and they were hyperintense on T1, and then there was some mild diffuse thickening of the sclerouveal cords. There was choroidal calcification, more pronounced on the temporal and nasal aspect, and there were some enhancing plaque-like lesions along the choroidal surface. The left eye was completely normal. So now what next? So the clinical findings were not really suggestive of retinoblastoma. I mean, the MRI, the imaging, there was no definite mass. But then we also wanted to rule out retinoblastoma. In this case, the child had presented with leukocoria, and we had instances earlier where these patients, later on, they don't show any evidence of retinoblastoma at presentation, but few months down the line, they come back with a definite mass, and, it looks more likely like RB. So we thought, okay, let's just go ahead with the genetic testing. And the right eye, the VR was extinguished. There was no visual potentials. When we did the genetic testing, the NGS for the RB1 gene, it showed that there was a heterozygous deletion on chromosome 13, classical of retinoblastoma, and then the genetic report came out as positive, and this RB1 deletion was classified as likely pathogenic. So now, is it retinoblastoma?
Let's look at the picture again.
Red cam, ultrasound, MRI, and genetics.
The photograph is limited. The question is it a diffuse infiltrating kind of retinoblastoma, if at all?
Yeah, so this was a 3-year-old child, not that not an older child, and the anterior segment was also normal. There was no inflammation in the anterior segment, and then there was some doubtful calcification on ultrasound. So these were some of the features that were going against a diffuse infiltrating RB. But yes, with a thickened membrane like this, we would definitely consider a diffuse infiltrating RB as a probable differential. No, this was it. It did, but that's why we were surprised at the genetic testing. So we, yes, so that's also one of the possibilities, that it could be incorrect genetics. But then, like, what do we do? Is it retinoblastoma? So we just, like, had this series of patients where, retinoblastoma was misdiagnosed. So this was about 208 series of about 280 cases, all of them enucleated at our center. So all these 280 enucleations were done for retinoblastoma. But out of these 280 cases, 4 cases didn't turn out to be retinoblastoma on histopathology. One was granulomatous endophthalmitis, one was a retinal astrocytoma, one was Coats, and one was PHPV. So 4 out of 280, almost 0.4% of cases where we misdiagnosed retinoblastoma, and finally it was on histopathology. But then these were all very closely simulating lesions, and all the imaging that was done in these cases were suggestive of retinoblastoma. That's why we went ahead with enucleation. But the point is that yes, we can, enucleate an eye which doesn't have a retinoblastoma, and later on histopathology, we get to know it was something else. So now the points to ponder in this case: how significant or accurate is this genetic testing result? Is it retinoblastoma? Should we go ahead with enucleation or not in this situation? And even if it's not retinoblastoma right now, if we assume that the genetic testing is correct, is this child at risk for developing retinoblastoma in the future, which is why we should go ahead with an enucleation right now? It's a non-seeing eye, it's unilateral, the other eye is normal. So how should we proceed?
Before you get into any of it, I want to know, is this test clinically validated? Do you know false positive and false negatives in this test before you clinically apply?
Okay, so
have you done it on 100 cases of RB and 100 cases of not RB, and you know what it shows, what are the predictive values? You need to know all that for this test before we start to rely on it.
Yeah, so we're not sure whether we should rely on it or not. So that's a very important question. And we contacted the lab when we got this genetic testing result. And we tried to find out from them what is their sensitivity, specificity, what would they suggest. Because clinically it is not looking like retinoblastoma to us. So what they told us, that they have done this, this targeted RB1 sequencing. Yes, Rita?
Why did you perform RB1 mutation in unilateral cases?
Yeah, that's a good question. In fact, we didn't want to miss a retinoblastoma. That's why we were not expecting, to be very honest, that we will get anything positive in the genetic testing. We explained to the parents that it's unlikely to be retinoblastoma. You can remain under follow-up, but they were coming from very far away, and they wanted, like whatever possible investigations to rule out a retinoblastoma. So that's why we offered. We said that, okay, you can undergo genetic testing. There's no harm. If we get a positive result, maybe it will, help us in our clinical management. If we get a negative result, then maybe we'll be more sure that it's not a retinoblastoma, and we can just keep you under follow-up.
So what did the company say?
Yeah, so the company said that we're always right. We're always right.
You have to produce some data.
Yeah.
Okay,
So, yes, this is...
You need to ask them to produce some validation data which should be publicly available.
Right. So when I checked with the company, then I went in the details of all of this. So then, anyway, I'll just tell you how we went ahead. So we explained to the patient that, look, this is the situation. Your genetic testing has come out positive. It's a non-seeing eye. And if you want, we can if you want, we can do an enucleation, but the probability that it's a retinoblastoma may not be there. So with an informed consent, if you're willing to go for enucleation, we can do the surgery, because that will take care of this problem once and for all. Otherwise, you'll have to be on, recurrent follow-up. And because the company also told us very categorically that maybe it's not a RB now, but if there is a RB1 mutation positive in the blood, then in the future, this child is likely to develop retinoblastoma, not just in this eye, but in the other eye also.
So that's German RB. 90% of them manifest by age 2.5. The child is already 3 years old.
Yeah.
Okay. So that event is very, very unlikely.
Unlikely, right?
So
Yeah.
they're giving you bullshit. Let me be very clear.
Yeah. So that's precisely why I'm presenting the case here, so that I can go back and tell them that you're giving us bullshit.
I mean, this is what it is. So you do a test, you spend some money, and doesn't take you to the right place.
Okay, right. So anyway, we went ahead with enucleation, but histopathology report was this. Dysplastic retinal cells with foci of calcification, bone formation, no evidence of malignancy.
Show us the name of the company so we can kind of.
Yeah, I've cropped it for now. So now the question, no. Now so, but I don't know whether we should go to another company or the same one for systemic genetic testing. So question here, was the genetic testing reliable? Then if it was, it's positive in a unilateral case, so this child requires more surveillance, assuming that the child has an RB1 mutation. It requires a greater degree of surveillance. He may be prone to increased risk for cancers, not just RB. And then we should do testing of parents and family members for genetic counseling. But if it is not, then what are the alternative tests? Should we go for MLPA, microarray, or other testing where, this can say that no, this is not a correct finding?
So let's say they were right in saying the child has RB1 mutation.
Yeah.
If you have RB1 mutation, 90% will manifest the disease, and most of it by 2.5. So that hasn't happened. The child is going to become 3 years old, otherwise will be uninvolved.
So yeah,
and
true.
Child doesn't have trilateral disease, you're doing the MRI, otherwise negative. This eye doesn't have RB, this eye doesn't have RB. So I would say, from the traditional understanding of retinoblastoma, this child does not have retinoblastoma. Now you have a test that's positive. We don't know the validity of that test. So the company has to produce validation data. How have they tested positivity, negativity of the test? If they cannot produce it, they should not be doing the service. You take them to ombudsman or whatever the authorities are. This is total, it's not service to anybody. It creates more confusion than anything else.
Yeah, absolutely. And this is one of the most reputed companies, without naming, but this is one of the most reputed companies which, are doing genetic testing left, right, and center for all these cases.
You let them know about this case?
I did. I asked them, what should I do now? They were like very confident that our results can't go wrong. Then I went back to the pathologist. I said, do some more sections and see, if you can find any evidence of tumor cells anywhere. Yeah, we can do that. Plus, we'll also now be testing the parents to look, because if it's in the blood, then maybe there are asymptomatic carriers. So we will need to go back to the parents. But then, yeah. But for now, I went back to the company and I went back to the pathologist and tried to get a concordance. But both of them are super confident that their testing is fine and their pathology report is flawless.
So my question, my further comment is that if you want to go further with enucleation, just do the genetic testing from the samples from the intraocular materials.
Right. Now that's a great point. So now we will do the tumor tissue. But so I want to, there's no tumor. That's the thing. There's no RB. There's no tumor, and the test is positive. And so has anybody had this kind of experience where you've had a positive genetic testing and a negative tumor?
For retinoblastoma to happen, both the mutations have been present in the tumor. So first there has to be a tumor, and there's no tumor. So that finishes the discussion. There is a tumor to show you the mutation. There isn't.
There isn't.
So
But it's in the blood, right? So that's the problem.
no, the problem is it's not there. It's just a misinterpretation.
Okay.
That's what it's telling us. Every way you look at this, there's no retinoblastoma.
So does that mean that in future we have a situation like this where clinically an imaging doesn't look like an RB and we have a positive genetic testing? Can we just leave the child and keep under follow-up? Is that the way to go about it?
So
Next time we have a patient, because we keep having these very often such cases that don't look like RB.
So you should choose a different lab. You can take the next sample and send to other reputable lab.
Or maybe we send to 2 different labs.
Okay, and then let them tell you what.
If it is a tumor, it has to grow. For
Yeah.
follow-up with patients coming for 1 month, 2 months, and you say nothing is changing
Yeah.
within the eye, I think invariably it rules out that there is a pathological tumor growing within the eye.
No, we do that very often. Such cases we always keep under close follow-up. And we know if it is growing or it is showing. So we usually keep them under close follow-up. We don't really jump into genetic testing for everyone. But in this case we did. And somehow it just turned out to be unexpected. Yeah.
The nucleus, nobody is questioning that judgment. It's the rest of this interpretation of the testing. So unless the company has to come up with some data, we don't know what it means.
Yeah, and we just don't know what we have learned from this case, whether we should change our strategy, do genetic testing in all the cases, rely on it or not rely on it, or just switch to our old strategy of just keeping all these patients under clinical follow-up and depending more on our clinical judgment rather than on these tests. Thank you.
So, good morning. So, for the last case of this instruction course, will be presented by Dr. Tarjini Dave, one of the colleague from LV Prasad Eye Institute, and she will be sharing an interesting case of orbital tumor. Over to you, Tarjini.
Thank you very much, Vishal and Professor Singh, for having me. I think my slide is there, okay. Right, so I'll get started without much ado. I have informed consent for full face photos, and this is the patient that I'm going to discuss today. He's a young boy, about 14 years of age, has never taken any ophthalmology opinion before this. Complains of a 2-year history of protrusion of the right eye. He had no visual symptoms, and the ocular examination essentially was normal, excepting the globe dystopia that you're able to see, a very anteriorly placed medial canthal tendon that you can also see over here. He did not have much proptosis like you can see on the worm's view, but certainly had lateral dysplasia of the eyeball. And obviously the next thing to do would be to image the patient, and here you see soft tissue and bone coronal cuts in the anterior part where you can see this large lesion which is sino-orbital in the medial orbit, sclerotic periphery, lytic center. One part of the lesion is continuous with the fovea ethmoidalis, very close to the skull base. This extended posteriorly until the mid-ethmoids, as you can see over here, and since it was abutting the eyeball, that is what was producing the lateral globe dystopia in this patient. The nasolacrimal duct seemed to be spared. The syringing was patent, and the bone around the posterior part of the NLD possibly was involved with this large bony lesion. These are just soft tissue and bone reconstructions of the more posterior part of the lesion, where you can see that it's ending at the level of the mid-ethmoid. A large part of it is obviously in the ethmoids, and a 3D reconstruction showing you the lesion very close to the roof, obviously close to the skull base on the nasal side, involving the entire medial wall in the orbital side. And the next obvious question is that he's symptomatic. It has been growing for the past 2 years. He's obviously seeking resolution of his symptoms, and therefore you'd want to excise it. But how do you go about removing such a large osseous lesion from the orbit? And when I think of orbitotomies, I divide the orbit with these crossbars into 4 quadrants. And obviously your lesion is in the medial quadrant, so something that gives you access to the entire medial wall is what you would kind of want to look at. 2 approaches here can be combined, which is going through the orbit as well as endonasal, to kind of approach this tumor in totality. I opted for a transcaruncular approach, which goes through the caruncle, is minimally invasive because the scar is not visible, and allows you access to the entire medial wall. And these are few intraoperative shots. Once we exposed the tumor, I had to use a drill to drill into the sclerotic part of the tumor, which I showed you earlier, within which was the more lytic component, which is easier to remove. And I could completely remove the tumor through the transcaruncular approach. You can see that these are all the areas where I have drilled on the orbital side, and once that thick sclerotic component was kind of out, I could just easily maneuver and rock the tumor with the help of a mosquito and remove it from the ethmoid side, which is over here. Some part of the tumor was adherent to the fovea ethmoidalis, and removing that is disastrous because it would have led to a CSF leak, and a medial CSF leak is extremely dangerous for the patient. Here's the pathology, which showed fibrous stroma with bony trabeculae, both. These are courtesy Dilip Mishra, our pathologist at LV Prasad Eye Institute. And what was interesting to note in the tumor is what is known as osteoblastic rimming, which you notice here where the arrows are. And this is very classic of osteofibrous dysplasia. This is a little different from classic fibrous dysplasia, where you have largely fibrous component. In osteofibrous dysplasia, as the name goes, you have some bone component as well, which is immature bone and can be made out by the pathology. And why is it important to know this? I'll get to that a little later. This is him 3 months after the surgery. Well, the one part that I missed is, as I removed this tumor, I also reconstructed the defect in the medial wall with the help of an implant. Here, an absorbable polycaprolactone implant, what is called off-label as osteomesh. He did have tearing. His lacrimal system was patent, but this tearing is more because of the anterior positioning of the medial canthal tendon and the so-called centurion-like appearance. This is him pre and post surgery, and I've used, like I mentioned, an absorbable implant, which is generally radiolucent on post-operative imaging, and that's the location where the implant was placed, and I was able to remove most of the tumor, like I showed you in the clinical picture as well. And this coronal part shows you the region near the fovea ethmoidalis post-operatively, this area, where obviously there is some residual tumor at this point of time, but drilling that would have disastrous consequences, and therefore I decided against chasing it. Here is the pre and the post 3D reconstruction showing you that the tumor is largely removed. The only word in this slide is, when I went back and did a literature search, osteofibrous dysplasias of orbit have not been reported. They are largely in the tibia. And there is a small chance of transformation to a low-grade malignant bone tumor known as adamantinoma in these lesions. So now the question is, the Ki-67 index here was very low. Is this a child who requires further radiotherapy? He's just 14 years of age. I didn't think that that is something that he should go through at this point of time, given that the growth and the recurrence is very low, and we've just kept him under observation. But this was probably one of the most surgically exciting cases in the orbit that I have operated. Thank you so much.
Very nice case. Over the last few years, we're doing more and more transorbital approaches. So we'll join with a skull-based neurosurgeon, ENT people, and have complete excision.
Yes, so we do have those, skills in-house. A lot of us do endoscopic surgery as well. We are trained to perform endoscopic DCRs, endoscopic medial wall decompressions, and we are trained to learn where the skull base is. But I do agree with you that having a skull-based surgeon would help drill that residual part, and if there was a defect, reconstruct that defect so that there is no CSF leak post-operatively. Yes, that could have been a possibility, and I certainly do agree.
That can take many hours, into like 4 hours of job, like whole morning is done, with many things. The neurosurgeon is there, the ENT surgeon is there, and going up the nose, going this, going that, you do your part, then you stop and then do their part, they pull out to the nose, and they do the sinus and come out. So I know it's a lot more draining of resources, but perhaps that's in an ideal world that perhaps is better.
Agreeable. Since this was a bony tumor, it wasn't pliable and flexible like cavernous hemangiomas are, which can, you can readily squish them out of the nose no matter what the size. Removing this just from the nose would have been very difficult in a 14-year-old. So certainly the orbital approach would be required. Like you said, and I agree with you, having a skull-based surgeon might have helped taking out that last bit near the fovea ethmoidalis, which you otherwise as an orbital surgeon would kind of fear doing, given the immediate CSF leak that you would see on table.
So I wouldn't do radiation because radiation itself is oncogenic.
Correct.
So if at all you want to do something, maybe you can ask neurosurgeons to go back and remove the rest of antifibrils.
Right.
That may be the best thing for him. It's small enough, localized enough, you don't have to do anything, and that is better than for him to come back with a recurrence, which will be more difficult resection down the line.
Right. And at what frequency, if you decide to observe, would you image him?
You can choose any number and it will be right. So I think the answer really is to go for the remaining tumor because of the risk of malignancy down the line. Say he's 20 years out, he's now 44 years old, there's a malignant tumor right there under the frontal lobe. Not a good outcome.
Agreed. Yes, probably that's what we'll do. We'll send him to a skull-based surgeon.
I like that kind of neuro-combined approaches. They bring different instruments.
Absolutely, absolutely. And, it's an advantage to be in a standalone eye institute, but it's also a disadvantage at times when you want to collaborate for cases like these. I completely agree. For us at LV Prasad Eye Institute, I think this is one of the things where we depend heavily on a radiation oncologist, a surgical oncologist, a skull base, an ENT, a maxillofacial. Only then can you have complete outcome in cases like these.
There's more and more, at least in the neurosurgical literature, there's more about it. They're very excited to extend it to the orbital. I see them bring different instruments. They basically will phaco a schwannoma in the orbit. He said, reason is the act of removal is enough to decompress the optic nerve, or to cause damage to the circulation. And that's how they do vestibular schwannomas. They do phaco vestibular schwannoma. So this man had a schwannoma by the optical apex, by the optic nerve. He phacoed in front of him. He had different instruments, basically ultrasonographic fragmentation. In the capsule, he decompressed the schwannoma, and then I removed the capsule. It was
Yes.
just like what they would do for vestibular schwannoma. It was amazing.
Yes. Right. Thank you very much.
Okay, thank you all. So we had 5 excellent presentations ranging from anterior segment to posterior segment and invading the orbit also. So if there are any questions, we'll be happy to take. If not, we can reach out to any one of us for any comments or any suggestions. Thank you all. We'll wrap up this instruction course. See you all. Enjoy Delhi and you have a safe travels back home. Thank you.